Start with the first class in gynecology, anatomy. Of course, this has been taught to you previously. So this is actually will be a review class, and it will be more applied anatomy. That means useful part of the anatomy than the gross anatomy. So let us review, because certain terminologies are there in gynecology that has to be known. Otherwise, you will not be able to read the subject even, and possibly you will be distributed in the clinical ward side also. This is anatomy, and this consists of reproductive organs. This is internal genital organs and external genital organs. The internal genital organs includes, you start from here, that is ovaries, then comes the fallopian tubes, then the uterus, then the vagina. This is internal genital organs. Again, this you can divide into, from the clinical aspect, two parts. One is from the cervix upwards. This is upper genital tract. And from cervix downwards up to vulva, this is lower genital tract. So, more important is the upper genital tract, because you see, this is communicating directly with the peritoneal cavity. So, any infection from here can travel and reach the peritoneum, causing pelvic peritonitis, from their general peritonitis. So, we are all concerned much about the upper genital tract than the lower genital tract. And uterus, you know, this is a muscular organ which is responsible for cyclical bleeding and also for carrying the pregnancy. That you know about the function. And the measurement is important. From here, measurement means from external os. These are the terminologies you have to remember. You have to rather practice. This is external os from the cervix up to the fundus. So this is, the length is about 7.5 centimeter. So inner part from external os to the fundus, this will be 0.5 centimeter less. So it will be 6.5, 1 centimeter less, 6.5 or 7 centimeter. So if the length is increased, we can measure the length by an instrument you will face in the word, that is called sound, uterine sound. That is not for sounding the uterus. The name came from the sound, but that is actually a rod, straight rod, to measure the length of the uterus. So there are certain conditions where the length is increased. There are certain conditions where the length is decreased. So accordingly, disease will be diagnosed, whether the uterus length is increased or length is decreased. Not only that, when you are passing some instrument, we have to remember the length. You cannot pass the unusual length. Then you easily perforate the uterus. So that's the importance. Unless you don't know the length, you will be able to negotiate the instrument much. Though you will face some resistance here, but sometimes it may be so soft, you may not feel the resistance and you pass the instrument upwards. So if you know the length, then you should not pass the instrument beyond that measurement. So that is the importance of knowing the length, and slightly larger in multipara than in nullipara. So if the length is increased by ultrasonography measurement, so instead of 7.5 it is 8 or 8.5, you need not bother, because if it is multipara shown, that is normal. So you do not bother about the length in case of multiparas if it is slightly more. Next come the divisions. That is very important. Divisions, you know, uterus, this is the whole uterus, and this is, see, the middle portion is constricted. That is called isthmus. Very, very important in pregnancy, because this isthmus, this is about 0.5 centimeter. 0.5 centimeter is not, it is written somewhere else. So this part enlarges up to 4 centimeter during pregnancy, and that forms the lower uterine segment. The lower uterine segment, you know, there is a term during cesarean section, we call it LSCS, lower segment cesarean section, because the cesarean section done to this portion, not through the 0.5 centimeter, but this becomes 4 centimeter during pregnancy because of the enlargement of the uterus. So isthmus is also enlarged. Not only that, this lower uterine segment is identified by the loose attachment of the peritoneum. Here the peritoneum, that is outer cover of the uterus, is closely adherent. In the cervix, it is also closely adherent, but it is the lower uterine segment where you can easily pick up the peritoneum during pregnancy. Thereby, you identify the lower uterine segment and we incise, we cut over the lower uterine segment to reach the uterine cavity to deliver the fetus. So, about the uterus, the lower uterine segment, the isthmus is very, very important. You see, there is a lining of the uterus is called endometrium. So this is myometrium, the muscle of the uterus is myometrium, lining is endometrium, and so lining of the cervix is endocervix, and this is you see the attachment of the fallopian tube, this is cornu, and the part above this fallopian tube, above the cornu is called the fundus, and below the isthmus it is the cervix. Cervix again has got two portions. One is intra-abdominal portions divided by the attachment of the vagina. From here the vagina is attached. Vagina is attached from here. So above the attachment of vagina, it is the supravaginal cervix, which is intra-abdominal. And below the attachment of the vagina, it is the vaginal portion of the cervix, and that is called your ectocervix, and this is the supravaginal portion of the cervix is intra-abdominal. So fundus, body of the uterus is divided into fundus, then is the body, and then is the cervix, is not the part of the body, is the part of the uterus, and the isthmus lying in between. So these are all important part to know. And endocervix is the lining, endometrium, metros means uterus. So myometrium is this, endometrium is this, and this is the lining. We are coming to that one by one. And structures attached to the cornu. So here is the cornu. What are the structures? You know, round ligament and fallopian tube and the ovarian ligament. What's the importance? When you will be given a specimen of uterus in the museum is there, you will be asked to know, to identify which one is the anterior wall and which one is the posterior wall. So it is the round ligament, attachment of the round ligament. If you can identify the rounded A-like structure, long structure, that is the anterior surface. And if you can identify the ovarian ligament, a ligament which is attached to the uterus from the ovary, then that is the posterior surface. So it is not the fallopian tube by which you will be able to know. It is the attachment of the round ligament in the body also, whether you are dealing with the anterior surface or if the uterus is rotated. How to know it is anterior surface, which one is posterior surface? It is by the attachment of the round ligament. So round ligament is anteriorly and ovarian ligament is posteriorly. So fundus and cornu, you see the narrowest portion, this is the attachment of the tube. So attachment of the tube, coming to that, the tube has got so many parts. One part is 1 centimeter is lying within the myometrium. That is intramural portion. That is the narrowest part. So that is the intramural portion of the fallopian tube. So here is another term, histological internal os. So this is anatomical internal os. Anatomical internal os, see, if you pass a instrument here, you will find a resistance here because there is a internal sphincter of the cervix. So that is called internal, this is external os, this is internal, you will feel a resistance. So thereby you know that it is the length of the cervix, you know. So length of the cervix may be increased also in certain conditions. It may be congenitally long. So that will be known by this thing, by the internal os. So histological internal os. So this is the endometrium. So endometrium and gradually coming down and merging with the endocervix. So it it crosses the anatomical internal os. So histological internal os lies below the anatomical internal os. So that is the thing to know. Otherwise, histological internal os is not that important. Then coming here, you see the isthmus and everything is shown here, and the ligament of the ovary. So this is the ligament of the ovary, and you see how the fallopian tube is attached, is related with the fimbria is related to the ovary, so that during ovulation the ovum can be easily picked up and transported through the fallopian tube up to the uterus. So that is the isthmus, and here the 4 to 5 millimeter, that means 0.5 centimeter is the isthmus, and the lining of the endometrium, that is coming later on, it is lined by low columnar epithelium, is the low columnar is the isthmus, and the cervix is columnar but not ciliated, and this is also columnar cells. So all are columnar but not ciliated. So during pregnancy, forming the lower uterine segment is 10 centimeter during the last trimester. So that is already stated. And this is the lining of the cervix is what we call endocervix, which is branching glands. The uterine glands are not branching, tubular glands, but glands here is the racemose. It is called racemose glands, branching. The importance is, if it is branching, when the infection is there, it is not easily cleared. So cervicitis persists for a long time, and the cervical canal is the cavity you see with the uterine cavity and with the exterior. Measurement of the cervix is 2.5 to 3 centimeter, and during pregnancy it enlarges up to 4 centimeter. The elongated lower part of the uterus is cervix. So next you come, these are the two terminologies, anteverted, anteversion, anteflexion. These you have to know. You see the uterus is bending forward and remains in an angle with the vagina. Create an angle with the vagina, so that is called anteversion. That means fundus is looking towards the anterior abdominal wall. So by abdominal palpation, if you can get the fundus, that means uterus is anteverted. So that can be easily found by the bimanual examination. So putting the finger over the abdomen and putting the finger in the vagina, if you find that fundus is felt, that means it is anteverted. And if it is not felt, it is retroverted. So fundus will look towards the sacrum. So if it is looking upwards, then it will be mid position, but usually it is either anteverted or retroverted. So importances are there about the anteversion and retroversion. Retroversion will cause problems, especially during pregnancy. And retroversion sometimes it is fixed, so that will cause back pain or like that if it is fixed. Otherwise not. Otherwise retroversion and anteversion, 80% is anteverted, but 20% is a natural phenomenon of retroversion that will not be taken as abnormal. So anteversion and anteflexion is the fundus angle between the body and the cervix. So this is anteflexed. So if it is anteflexed, so if you try to pass instrument, you will not be able to pass, because then you have to carve. So you can easily, if it is acutely anteflexed, you can easily perforate while passing the desirable length of the sound of the instrument. You can easily perforate the posterior wall of the uterus. So either it is anteflexed or retroflexed, that you have to know before doing any operation. Otherwise you can face that accident. So by support of the cervical, endocervical fossa and pelvic floor muscles, levator and eye, so many supports are there which keeps the uterus anteflexed. If they are not supported, then it may be retroflexed. Next is the relations. You see from the very picture, you know, the uterus anteriorly related to the bladder. So, and in between this is the peritoneal pouch, between the body of the uterus, lower portion of the uterus and the bladder. This is called uterovesical pouch. How it is written? This is vesico-uterine pouch, or you can say uterovesical pouch. So, that is uterovesical pouch. So, here if you try to do some operations, you have to push the bladder downwards. Otherwise, you will injure the bladder. So, you have to cut the peritoneum of the uterovesical pouch. So, unless you cut the peritoneum of the uterovesical pouch, you will not be able to reach downwards, that means towards the vagina. So, you have to push the bladder downwards, which is definitely needed during lower segment cesarean section. We do the cesarean section through this area, so you have to push the bladder downwards. Unless you do cesarean section through the body of the uterus, you cut the body of the uterus, that is called upper segment cesarean section. So, usually we do not do nowadays, upper segment cesarean section is not done, because you see this is very much thick and very much vascular also, but lower segment cesarean section is thin. Even you have not to cut, you can split the fibers, because circular muscle fibers are mostly found in the isthmus. So, you can split, so bleeding is less. So, if you don't keep in mind that bladder is related to the, on the body you will not be able to identify bladder. Bladder is deflated. So, only by, if you have the knowledge, you cut the peritoneum here, loose peritoneum which is attached, then you push the bladder down. Then only you will be able to save the bladder, otherwise you will cause injury to the bladder. So, that is the anterior relation. Posteriorly you see, posteriorly there is no such thing, important structure, but the peritoneal cavity is there, and peritoneal recess you see, this peritoneal recess is this. So, this is called pouch of Douglas. Pouch of Douglas. So, upper 1/4 of the vagina is bare and is covered by the your recto-uterine pouch. That is called pouch of Douglas. So, here the important pouch of Douglas posteriorly related. Behind the pouch of Douglas is the rectum. So, if you cannot identify the pouch, you can injure the rectum. So, that means the pouch of Douglas is to be identified, and the laterally the broad ligament. Broad ligament contains so many structures, you know, all the structures of the pelvis passes through the broad ligament. So, if you have to know that in details, otherwise many vital structures will be injured during operation. So, pouch of Douglas, you see, if you cut the pouch of Douglas, so through the this is the vagina. So, here is the pouch of Douglas. So, if you can easily put a needle in the upper part of the vagina, vaginal wall, posterior vaginal wall, and reach the pouch of Douglas. If there is any collection, suppose pus, suppose blood, that can be drained easily through the pouch of Douglas. That is drained through the pouch of Douglas. So, that is called incision on the pouch of Douglas is called colpotomy. Colpotomy means incision on the posterior vaginal wall, the upper part. Colpos means vagina. So, pouch of Douglas is very important for, if it is full, if it is bulged, then you know some collection is there, and putting a needle, you can know the type of collection. So, by that you can diagnose. Not only that, when you are draining the pus, then that is a treatment also. Suppose collection, abscess, collection of pus in the pelvis, that is called pelvic abscess. So, pelvic abscess, you need not drain the abscess by cutting the abdomen. You can reach the pelvic peritoneum through the pouch of Douglas by putting an incision on the vaginal wall, transverse incision, go straight posteriorly, you will reach the pouch of Douglas. So, and the collection will be drained. So, that is the treatment, operative treatment for pelvic abscess. The importance of pouch of Douglas. And if there is pouch of Douglas is deepened, is more, then that will may contain intestine, and that is called deep pouch of Douglas, and that may come downwards through the along with the vaginal wall, and that is called enterocoel. If the pouch of Douglas is very long, it will come downwards through the vaginal wall, along with the vaginal wall, that is called enterocoel, which pouch of, that means herniation of the pouch of Douglas, which may or may not contain intestine. So, that is the importance of pouch of Douglas. The supravaginal cervix, that we are talking, that lower segment is attached, takes part in the formation of lower uterine segment. So anteriorly is related to the urinary bladder. The cervix, the abdominal part of the cervix is related to the urinary bladder. So if you do something on the cervix, you have to push the urinary bladder. Posteriorly, the pouch of Douglas is there, and laterally, that is very important. Lateral to the abdominal part of the cervix, what structure is lying? Lateral to the internal os, how much away, how much lateral? Half an inch, means 1.25 centimeter away from the internal os. Ureter is crossed by the uterine artery. Uterine artery is entering the uterus, and the ureter is passing below the uterine artery. That is, the picture will be shown. So that is the very important. If you do not know, if you do not care of the ureter, then during the cutting of the uterine artery or clamping of the uterine artery, the ureter may be injured, because that is lying just 1.5 centimeter. So whatever you do, either you have to displace this crossing laterally, or you have to lie medial to the less than 1.25 centimeter clamp. If it is more than 1 centimeter away, lateral clamp, so you will injure the ureter. So ureter may be tied or ureter may be cut. So that is the lateral relation of the vaginal portion of the cervix is very much important. The uterosacral, cardinal and pubocervical ligaments are attached to its posterior, lateral and anterior. Picture will be shown now. Uterosacral, cardinal. Uterosacral means from the cervix, posterior wall of the cervix, it is attached to the sacrum. Cardinal means the McIndore's ligament. From the lateral part of the cervix, it is running laterally, attached to the lateral wall of the pelvis. Pubocervical means anterior part of the cervix. It is anterior part of the cervix. It is attached to the pubic bone. So it is running under the bladder. That is called pubocervical ligament, or you may say pubovesicocervical. That supports the bladder. So those are all the things again will be discussed during the prolapse, diseases of prolapse. These are the supports of the pelvic organs. So pelvic organs usually main support is done by the vagina and its fossa. But vagina is indirectly supported by the pelvic floor. So pelvic floor is the main support, above which the ligaments are there, and above and which is supporting above which the vagina, and vagina is supported by all these ligaments. So where is this picture? You see, this is the cervix, from which posteriorly running the uterosacral, laterally running from the cervix, laterally running the transverse cervical or cardinal ligaments or McIndore's ligaments, so many names, and posteriorly it is uterosacral ligament. Posteriorly it is uterosacral ligament. These are indirectly supporting the vagina also, and supporting the uterus means supporting the cervix. Attached to the cervix means it is supporting the uterus. Uterus cannot come to the vagina because of all these supports. So this is the supports of the uterus. So already I have stated that endometrium is the lining of the uterus, then myometrium is the muscle, and the peritoneal cover is called perimetrium. These are all terminologies. You have to remember that. That's why I am repeating these things. Histology of the uterus. You see, the endometrium is columnar epithelium or cubical, straight glands, and so cyclical changes with the menstrual cycle. That will be taught in details during the menstruation, classes of menstruation and ovulation. So cyclical changes, and you know that cyclical changes means one is proliferative and another is secretory, that you know from your knowledge of physiology, and secretory is known by the presence of subnuclear vacuoles. That is very important, whether the secretory change only occurs following ovulation. So secretory change means ovulation is occurring, no doubt about that. So then is the myometrium. A myometrium is called 3 layers. This is very important. Outer is longitudinal, which is very not strong, but middle layer is interlacing crisscross muscle fibers. That is crisscross muscle fibers. Picture I cannot show. That is called living ligature. Because of that muscle fibers, when it contracts, it occludes the penetrating vessels through the uterus. That's the mechanism of stoppage of bleeding following operations, following delivery. So that is called living ligature. If the uterus fails to contract, then the perforating vessels from the uterine artery will not be blocked, so hemorrhage will go on. And the inner circular muscle there, you know, is very weak, except at the level of the cervix, which causes the internal, causes the internal formation of internal os, which is responsible for keeping the pregnancy within the uterus. So if it is not strong, the pregnancy will be expelled. Uterus will be, if it is dilated, internal os will be dilated, and pregnancy will be expelled. Then perimetrium is the attachment of the uterus, and only thing you have to remember is Douglas pouch, already stated, and laterally it is causing the broad ligament. Broad ligament, anterior pouch of basic uterine pouch, we have already discussed. Then histology of the cervix, columnar racemose glands, that is the important to remember, which once infected, very much difficult to treat that infections, so it causes repeated infections, and that's why the chronic cervicitis can occur. And ectocervix, you see, the ectocervix is lined by, so this is important, endocervix is lined by columnar epithelium and the racemose glands, but ectocervix is lined by stratified squamous. The epithelium like vagina is lined by stratified squamous, and ectocervix is also lined by the stratified squamous. So that is very important, and in between these columnar cells of the endocervix and squamous cells, stratified squamous cells of the ectocervix, in between is called Squamo-Columnar Junction. So that is a terminology you have to remember. Squamo-Columnar Junction, SCZ, Squamo-Columnar Junction. That is the area where changes takes place during the hormonal variations of the cycle. So when the hormones levels are very high, so it moves downwards. When it's very low, it moves up. So that variation occurs. This area, because of the epithelial changes, it is very much vulnerable to develop carcinoma of cervix. So carcinoma cervix takes place at Squamous-Columnar Junction. So commonest type of carcinoma is this from this area. That means squamous. So this is columnar, this is squamous. But commonest carcinoma is squamous cell carcinoma. From where it arises? From the Squamo-Columnar Junction. Why? Because that area always undergo changes. That's why. So carcinoma develops where there is changes always. So proliferation. Because of this, the control of proliferation will be lost, and there will be carcinoma. That's why Squamo-Columnar Junction, that is transitional zone. That is another name is transitional zone. 1 to 3 millimeter from this columnar to squamous. Transitional zone. The junction between squamous and columnar epithelium at the external os is either abrupt or it may form a transitional zone gradually 1 to 3 millimeter, known as transformation zone. It can be visualized by a instrument. What is that called? Colposcope. Or you can say it colpomicroscope. That is a lens with magnification around 40 times magnification with a lens. If you focus it through the vagina, from the vagina, and if you expose this area of the cervix, and you will be able to note the picture of the columnar and picture of the squamous and in between area, and if there is certain changes which are characteristics of malignancy, then by colposcopy only you can know, you can screen that this area may be malignant. So you can do the histopathological examination, taking biopsy, and so you can diagnose the carcinoma early. So colposcope is a screening instrument for visualizing the squamous epithelium, bicolumnar epithelium, and the squamo-columnar junction. That is about the squamo-columnar junction, or you call it transitional zone. Then what about the blood supply? You know, uterine artery definitely is the blood supply. So this is the uterine artery, is entering here. So it sends one branches here at the level of, so we have already stated that it is entering at the level of isthmus, and it is crossing the ureter. So ureter comes from behind forward, comes from the pelvic wall, lateral pelvic wall to anteriorly to the bladder, and the uterine artery coming from the lateral pelvic wall straight towards the cervix, and it sends one descending branch which is supplying the cervix and vagina, and one ascending branch. You know, it is taught to us. Why it is taught to us? Because during pregnancy, uterus will enlarge. This taught to us, it will be lost. So that will accommodate. To accommodate the enlarging uterus, uterine artery is taught to us. Then you see terminal branch. One terminal branch is here at the cornu, and another is going towards along the mesosalpinx. That means brought to the broad ligament, parallel to the broad ligament. It is anastomosed with the ovarian artery. See, ovarian artery is a branch of abdominal aorta. So ovarian artery coming from here and entering here, and uterine artery coming from here is a branch of anterior division, internal iliac artery. So internal iliac artery is the uterine artery, and aorta is the ovarian artery. So here is anastomosis. So even if you tie the artery, so this anastomosis can maintain, this can maintain the circulation of the uterus. So that's why even the uterine artery is tied to control the bleeding from the uterus. Or uterine artery is blocked by some emboli, intrauterine embolization. Still the uterus will survive because of the anastomosis. So many anastomoses are there. One of them is ovarian artery with the uterine artery. So this area and this area of the cornu, where there is a terminal branch of the uterine artery, this ovarian branch is coming, so very much vascular. So if the cornu is injured during operation or during anything else, so vascularity is so that it is very difficult to control. It is supplied from both sides, from this side and this side. So very difficult to control the bleeding from the cornu. So that is the uterine arteries. And when we do the operation of hysterectomy for removal of the uterus, we clamp the uterine artery here. That means when it is ascending up, so that the ureter below, just below the uterine artery, is not injured, is not damaged, is not tied. So base of the broad ligament crossing, this is forming the base of the broad ligament, base. So after that is the pelvic floor. Just below this crossing is the pelvic floor. This area is pelvic floor. So lake of vessels, lot of veins, anastomos here. You will see the picture in the books. So crossing above the ureter half an inch lateral to the supravaginal cervix, half an inch lateral. So you have to you have to stay 1 centimeter medial to the, as close to the cervix as possible. So you have to stay here so that you are tying the uterine artery, and at the same time you are saving the ureter. And the 2 branches, one is ascending and one is descending. You see here is also, so this is the from the internal iliac artery, this is the branch of the uterine artery, and this is the ovarian artery. And you see, this is the crossing is shown. So the ureter is crossing and this uterine artery is entering the ureter. So we put the clamp here, not here. So if you cut here, so ureter will be damaged. So we usually push this down so that this area is clear and you can easily. And here, in vivo, this picture is shown as uterine artery is entering the uterus, entering the uterus. And here is the internal, this is the external iliac, you see, is going towards the laterally, towards the thigh, and this is the internal iliac. So often we have to do the ligation of this internal iliac artery, not internal iliac artery on the trunk, but on the anterior division, which is supplying the pelvis. Posterior division is supplying the gluteal region. It is through the forearm, it is going backwards. So that is posterior. If you tie it, then the lot of impairment of circulation, necrosis will occur. So anterior division only you have to tie. So from anterior division, all these branches, vaginal artery, uterine artery, all those things arises. So that has to be tied here. Here and here, the danger is, here there is internal iliac vein also. So that is a very important step. You have to save the vein. In tying the internal iliac artery, anterior division, you have to save the vein. If the vein is injured, that is a very dangerous condition. Artery can easily tie, but vein you cannot easily tie because venous flow is coming downwards, so not from the upwards. So very difficult to stop the venous bleeding. So that has to be saved, and always we try to pass the instrument so that ligature is trying to pass from lateral to medial, so that if you try to go from medial to lateral, the vein will be injured. But if you go from, relation is such, if you go from lateral to medial side, the vein will be saved. So that is the area for, after opening the peritoneum, you can tie the internal anterior division of the internal iliac artery. You see here it is shown again, the anastomosis. You see the ovarian artery is coming from this side and this side. So during the ovary, you see this is the ovary, and ovary is attached laterally by the broad ligament, that is called infundibulopelvic ligament, and medially it is attached with the ovarian ligament. So if you put a clamp here, so that is including this, your fallopian tube and the ovarian ligament. So you can put clamp here easily. So round ligament will not be clamped. So you can clamp here easily, and that is closed. And another clamp on the infundibulopelvic ligament, so thereby the ovarian artery will be clamped. So bleeding will be stopped from both the sides. If you could not clamp it properly, see, ovarian artery is a branch of the abdominal aorta. So if it slips, it will retract upwards and will cause retroperitoneal bleeding. So very difficult to go retroperitoneally. So many structures around the aorta, lateral side of the aorta is there. So ureter is there, so many vessels are there. So very cautiously you have to clamp and cut it. So slipping is dangerous because so pressure on the ovarian artery is direct from the abdominal aorta. So very difficult to control. Ovarian attachment of the ovary, and this is the round ligament, and you see from these are the branches of the anterior division of this is the uterine artery, this is vaginal artery, and some terminal branches, sometimes internal pudendal artery and other things are there. So pelvic area, pelvis is supplied by the anterior division of the internal iliac artery. So if you cannot control bleeding, or if the even following operation bleeding cannot be controlled, so you have to tie the internal iliac artery. So internal iliac ligation is very important to know for the emergency surgeons. Anytime this may come, that is a life-saving procedure. And if you, during your ligation, internal iliac artery ligation, if you injure the internal iliac vein, that is a very difficult situation. You may not be able to save the patient. A venous drainage, you know, it forms the pampiniform plexus of veins. All the veins from the vagina, uterus, and even from the ovary, so that from the pampiniform plexus of vein, from then arises the ovarian vein and the uterine vein, everything. So that is not much important. Important is this plexus. So if the plexus is injured, you will not be able to control it unless you tie the supply. Tie the supply means ovarian artery and internal iliac. So internal iliac artery ligation. So that is the importance. Lymphatic drainage is very, very important. It will be discussed in details during the operation for the malignancies of the uterus and cervix. But very important is lymphatic drainage of the uterus is from the fundus goes to the para-aortic nodes. That is very important. So from the uterus, if you try to remove its lymphatic supply or spread of the cancer, then you have to remove the para-aortic lymph nodes, which is not very easy for the average surgeons. The para-aortic lymph nodes. And from the cornu also to the round ligament. So round ligament means that is on the inguinal group of lymph node it is coming. So from the body of the uterus, so cancer if spread, it will spread at a distant area. So very difficult to remove all those things. From the body to the uterine, along the uterine vessels to the external iliac lymph nodes. So how are the lymph nodes you find in the pelvis? One is so paracervical obturator, then is internal iliac, external iliac, then from there is the common iliac. These are the lymph nodes you can remember from the picture. And so that isthmus is like that of cervix, so not separately is not very important. But from the cervix, two groups of lymphatics. One is primary group. That means sometimes that has to be removed to see at least whether the lymphatic spread is there or not. That is obturator, very much important, because obturator lymph node found in the obturator foramen, where there is obturator vein. So during removal you can injure the obturator vein, and where there is no other way to control, only by pressure and weight. Pressure and weight. So obturator vein may be injured during removal of obturator node, and obturator is called the sentinel lymph node, because after that from obturator it goes to the internal and external. Or it may directly sometimes may go to the internal external, but obturator is hidden node. So if you remove the internal external, if you do not remove the obturator, then from this node the malignancy will spread, and there will be recurrent growth in the pelvis, because you have been failed to remove the obturator node. So a paracervical, parametrial, then obturator, external directly may go to the cervix, to the internal, external all. So these are the primary groups. Secondary groups are common iliac, para-aortic, and lateral sacral lymph nodes. Common iliac, para-aortic. So after that, but during that the spread is so much, possibly distant spread will be there. So is not very much effective in preventing the growth. The chemotherapy will be better. So when at the primary stage, if somebody wants to remove the malignancy along with the drainage lymphatic nodes, then we remove usually the obturator, internal and sometimes external. Obturator, internal and external. That you have to remove. And during your removal, all the nodes are on the vessels, on the arteries and on the veins. So that could cause injury to all the vessels. So not a very easy thing. Always there is risk. Nerve supply. nerve supply is important because, number one, when we put regional anesthesia, we have to know at which segment of the thoracic and lumbar areas where to put the anesthetic drugs. So spinal anesthesia, that means you see parasympathetic and sympathetic. Sympathetic from T5, T6 motor and T10, 11, 12 is a sensory. So if you put anesthesia on T10, 11, 12, that means T10, 11, 12, that means lower upper lumbar and in between the lumbar and lower thoracic. In that case, the whole area will be, sensory loss will be there. So it is done during the CRN section. The CRN section we give spinal drug, lignocaine, at the level of below the T10, 11, 12 and L1. Thereby, one can do the CRN section over the abdomen. So abdominal, there will be no sensory sensation. So you can do the operation, you can cut the abdomen. And T5 and 6 is motor. That's why even with this drug, the motor function will not be lost. So uterus will be contracting, relaxing. So that is beneficial. And parasympathetic from S2, 3, 4. So that area is also the sensory things are there, sensory sensation. So S2, 3, 4. S2, 3, 4 is the lower back in the limb. So during labor pain, patient felt the labor pain at the back because of the supply from the cervix, sensation from the cervix, S2, 3, 4. So both the uterus to branches of the hypogastric plexus is the area from these segments. They communicate with the hypogastric plexus. From there, the supply is done. The cervix and body are relatively insensitive to touch. The cervix and uterus body has no somatic sensation. So sensation, there will be referred pain from there. So cutting and burning. So during the cervix, you can easily cut the cervix, but it is sensitive to dilatation. So you cannot dilate the cervix. You can do a cautery of the cervix, you can burn the cervix because no sensation, but you can dilate the cervix. So sensitive to distension. That is about the nerve supply. Fallopian tube, you know, that is very important, that 10 centimeter in length. So 1 centimeter is within the body of the uterus or cornu, 1 centimeter in the infundibulum, and 4 centimeter is the ampulla, and 2 to 3 centimeter is the 2 centimeter is the isthmus. So they blend medially with the cornu, laterally they are free outer cups backwards towards the ovary. Their lumen communicates between the uterine and the peritoneal cavities. And that is the fallopian tube. We see here the picture is the cornu at the uterine cavity and with the abdominal cavity. And so interstitial is 1 centimeter, isthmus is 2 centimeter, ampulla from here to here is 5 centimeter, most dilated portion, and infundibulum is 2 centimeter. It is often asked because we do the tubal ligation operation through where? Through this isthmus, because this area is more or less same caliber. So even following operation, if we want to go for reanastomosis, following cutting the tube, we go for reanastomosis, this area will be caliber is same, it will be easy to do anastomosis. Or this is the ampulla where usually fertilization takes place. So that is about the fallopian tube. And ovum pick up the tubal function. So ovum pick up by the fimbria ovarica, you know, the longest fimbria. Transport of the ova. How it is done? Through tubal lumen by their peristaltic movement and ciliary action. So ciliated columnar, tube is lined by ciliated columnar, ciliary action and productions of secretions necessary for capacitation of the sperm and nutrition of the ova during their journey by their lining cells. So there are some secretions from the tubal glands. So that is very important. Anatomical relation already with the tube is not so important. Tube is a free structure within the abdomen. So not very important to know. The only thing is attached to the cornu, and here is the ovary. The histology of the fallopian tube already stated, it is ciliated columnar. Ciliated peritoneal mucus is folds or plica. It is lined by columnar, partially ciliated columnar. And serosa is there, and muscle layer is thick, and the isthmus and the thin at the ampulla. This is the laparoscopic view. By laparoscope, if you look at the abdomen, you will be able to see the uterus is like this. Ovaries are white structures, and behind the, in front of the uterus is the bladder, and behind the uterus, the peritoneal cavity, and behind which is the rectum. So rectum is looking like that. That is the fat of the serous coat of the rectum. So that is laparoscopic view. And coming to the vagina, the important is length of the vagina is posterior length is more, 10 to 11 centimeter, anterior wall is less. And phonesis, this is the term you have to know, vaginal phonesis. What is vaginal phonesis? This is the area between the, or it is the space between the cervix, vaginal portion of the cervix, and the upper part of the vagina. So posterior phonesis is deeper, or anterior phonesis is shallow. So anterior phonesis and posterior phonesis. Through the posterior phonesis, you can know what is lying within the abdomen. If there is any tumor, you can feel this through the posterior phonesis. If there is tumor anteriorly, you can feel this through the vaginal phonesis. Because this area, vagina, is a very thin wall, so through the abdominal wall you will not be able to feel, but through the vaginal wall you will be able to feel. So this is the vaginal phonesis, very important, and this angle is there. So vagina causes angle with the pelvis, pelvic floor. That is very important. That indirectly is causes support. And in front of the vagina, you see, the vagina is relation we are coming. Vagina supports, before that. So come to the relation. You see, relation here, the vagina, upper part of the vagina is related to the trigone of the bladder, and lower part is related to the urethra. So lower portion is related to the urethra, upper portion is related to the bladder. So if the upper part of the vagina descends downwards, so that is the bladder which will come downwards. That is called cystocele. If the posterior vagina descends downwards, so relation to the posterior vaginal wall is the rectum. So rectum will come downwards, that is called rectocele. So that is called prolapse. When the vaginal wall descends downwards because of loss of support, it will be called prolapse. So when the anterior vaginal prolapse or posterior vaginal prolapse. Anterior vaginal prolapse means cystocele, urethrocoele. Posterior vaginal prolapse means rectocele and enterocele. So pouch of Douglas is also upper part of the vagina, enterocele. And uterus, you see uterus, if it becomes retroverted, it will come along the line of the vagina, it can come downwards and it will be uterine prolapse. So pelvic organ, there may be uterine prolapse, maybe vaginal prolapse. Vaginal prolapse means either cystocele, urethrocoele, and posterior vaginal prolapse means rectocele and enterocele. And then the vaginal supports. So vaginal supported, as you have seen the picture, pubocervical ligament, McIndore's, and uterosacral. So levator muscle is very, very important. So levator hiatus, if it is enlarged due to childbirth, if it is not restored, then the vagina which causing angle with the pelvic floor will be lost. So there will be a loss of support on the vaginal, and the vaginal fossa, which is nothing but condensation of the pelvic cellular tissue. So embryologically, in between the viscera and the pelvic floor, there is nothing but the connective tissue. So those connective tissue, after condensation, forms the different fossa. Those fossas are, these are the fossas. Condensation of pelvic tissue is causing fossas, we have already mentioned. That means McIndore's, pubocervical, and uterosacral, and so that is the muscles, and this, and anatomical relations were already stated lot different times. Vaginal mucous membrane, which I already stated, it is squamous, stratified squamous, and there are folds, they are folded, thrown into folds. Vaginal mucous membrane is this, thrown into folds. That is called ryugi. How do you know that it is a vaginal wall? It is not a wall of the cervix. It is cervix in vagina because of the presence of ryugi. You see the axis, the vaginal lumen, when opening at the vulva, it is longitudinal, but at the middle, it is horizontal. So when you are trying to pass some instrument, you have to pass vertically, then you have to rotate it so that it goes horizontally. So vagina is anterior wall and posterior wall, and H separate lumen, and this is the supply of the vagina. This is the other than uterine artery, it is vaginal artery and rectal, inferior rectal artery also. And so lymphatic drainage and nerve supply is not that important. Ovary is very much important. That has already been stated. Infundibulopelvic ligament and this thing. And this is the ovarian attachment. So infundibulopelvic, and here is the ovarian ligament. The mesosalpinx, this is the ligament of the, this is round ligament. Mesovarium means leaf of the broad ligament through which the ovarian artery and everything enters into the ovary. So anterior layer. Ovary is cortex and medulla, you know, and hilum. And cortex is the main area, functioning area. Medulla is the full of vessels through which the vessels, lymphatics all enters. And this will be taught in details during the ovulation. The ovarian artery is entering, and follicle at different stages of development. This is corpus luteum. This is ovulation is occurring. This is the mature follicle about to rupture. This has been ruptured, and this is the primordial follicle, and this is the different stages of follicle. And venous drainage, not lymphatic drainage of the ovary, very, very important, para-aortic lymph node. So in case of ovarian carcinoma, you have to remove the para-aortic lymph node because the lymphatics run along the vessels, ovarian vessels, which is a branch of the abdominal aorta. So para-aortic lymph nodes are involved, from which easily metastasis into the chest. So that is the ovarian vein and ovarian artery directly coming from the pelvic part of the uterus. No time to discuss. Blood supply of the ureter from different artery, you see. Ureter is supplied by internal artery, uterine artery, inferior vesical artery, vaginal artery. So, sacrifice of one artery will not cause anything to the ureter unless the vascular sheath of the ureter is damaged, or they causes anastomosis, from which there is supply. Broad ligament, you see contents of the broad ligament, ovarian ligament, everybody. This is the diagram, McIndore's ligament. This is uterosacral. This is pubocervical. This is the pelvic floor. This is the pelvic floor from the levator ani muscles and from this the superficial perineal muscles. They cause the pelvic floor. So attached to the vagina is attached with the pelvic floor. So this is the plexus, this is the vessel, external genitalia, not so important. The hymen is important, it may be imperforate. So, and it may be cribriform, it may be like this, usually deflorated, it may be bifurate, maybe. So it is the virgin hymen, and this is the penetrated hymen, so like this. So if you can feel the circular ring around your finger, that means it is a virginal hymen. That is medico-legal importance. So venous drainage, after lymphatic drainage of the vulva is very much important. Lymphatic drainage. They are either the superficial inguinal, deep inguinal, and femoral. This is the lymphatic drainage of the vulva. Superficial inguinal, deep inguinal, and femoral, and to the from this superficial group, lymphatic channels pass to the deep pelvic nodes, including external iliac, common iliac, and palliative. So, during vulval carcinoma, lot of lymph nodes you have to remove, so very big operation. So, embryology we should not discuss. Only two things is important for embryology. One is you see, it develops from one is mesoderm of the intermediate cell mass and another is urogenital sinus. Urogenital sinus means anterior part of the cloaca from which vestibule and part of the vagina develops, and mesoderm of intermediate cell mass where there is thickening is called genital ridge, from which medial part give rise to ovaries and from lateral part give rise to fallopian tubes, uterus, and upper 3/4 of the vagina. So vagina develops upper 3/4 from the intermediate cell mass, which is called the paramesonephric duct, and ovary from the medial part is the gonadal ridge, and lower 1/4 developed from the urogenital sinus. And you see the ovary you see here, from the hindgut, the germ cells migrate at about 6th week into the genital ridge, which is thickening on the intermediate cell mass. So you know the intermediate cell mass has got medial part, has got lateral part. It is the middle intermediate part from which the genital uterine system develops. So thickening is of the mesothelium, from which the cord of cells go into the mesenchyme, and they breaks up at the presence of this migrated primordial germ cells, which cause the primordial follicle, and the follicle develops. So it is the coelomic epithelium from which the granulosa cells develops, and germ cells or ovum comes from the migration from the gut, from the yolk sac, from the gut. After the germ cell reaches this gonadal ridge, then the organization of the sexual cord cells or sexual strema develops. That is the development of ovary. And you see here, from this area, so this is the embryo, this is the mesoderm. So medial, not the medial part, the intermediate part where this genital urinary system is developed, and this lateral part gives us to coelom, and this is not so important. So you see, the gonads are derived from three sources. One is primordial germ cells, comes from the yolk sac. One is mesothelium, that is mesodermal epithelium, lining the posterior abdominal wall, and underlying mesenchyme, that means embryonic connective tissue. And you see here is shown there, it is the ovary, and here there is another tube-like structure from the coelomic epithelium that is called paramesonephric duct. Medial to that is mesonephric duct, which takes part in the formation of Wolffian duct. We are not concerned. From the paramesonephric duct, there is a duct which runs caudally, the paramesonephric duct. This is Wolffian duct, this is the paramesonephric duct. This is coming downwards. At the midline, they are fused. So fusion of the paramesonephric duct causes development of the uterus. An unfused portion causes the development of the fallopian tube. At the junction of the urogenital sinus, reaches the urogenital sinus, at the junction of the urogenital sinus, you see, at the junction of the urogenital sinus, there is formation of vaginal plate. Yes. This is sinovaginal valve, and causes vaginal plate, after canalization of which causing the vagina. So cervix and upper part of the vagina develops from the paramesonephric duct, but lower 3/4 of the vagina develops from the urogenital sinus. So vagina develops from the two sources. That's why vagina is covered by the squamous epithelium.